Speaker for today is a clinician, Dr. Chiwi Mok from Changi General Hospital from Singapore. He's currently a consultant in the Department of Surgery, and his work is mainly on the breast diseases, both benign and malignant. And in Singapore, basically, he has developed two new minimally invasive breast surgery techniques, which one is a three-dimensional endoscopic subcutaneous mastectomy. And today he's bringing to us also an integration approach in the clinical system, which is a multidisciplinary team approach, the crux of breast cancer management in the new normal, which means in the face of the pandemic. So let's welcome Dr. Mo.
Hello, a good day to everyone. First of all, I have to thank the editorial board from Biointegration for inviting me to speak today. And I'll be sharing on this topic that is close to all of us here, I believe. That is how we manage patients in the new normal in the COVID-19 pandemic era. So today, I'll be sharing with all of you the multidisciplinary team approach, which I feel is the crux of breast cancer management in the new normal. I'm Chiwe from Singapore, and I practice as a consultant oncoplastic and minimally invasive breast surgeon. To give a little bit of background, I think all of us would have realized that the COVID-19 pandemic has forced healthcare institutions around the world to direct resources to better manage the pandemic. This has inevitably resulted in a sudden acute limitation of resources to care for non-COVID patients with critical conditions. In Singapore, we are no exception. The escalating situation at the initial start of the pandemic has necessitated swift reaction in the Division of Breast Surgery in Changi General Hospital to develop strategies to support the battle against COVID-19 on one side, and yet deliver care to our breast cancer patients at the same time. This paper that was initially published last year described the challenges faced and measures adopted by the division during this pandemic in our multidisciplinary management of non-COVID breast cancer patients. It is therefore our fervent hope that this article will serve as a guide for physicians or surgeons in similar settings who are managing breast cancer patients amidst this pandemic. The first case of COVID-19 in Singapore was first reported on 23rd January 2020. Back then, Singapore actually had the highest number of reported cases outside of China by the end of January 2020. Consequently, the Ministry of Health raised the level of the Disease Outbreak Response System condition, in short known as DORSCON, from yellow to orange, signifying that the disease was severe, spread easily, but was still contained. Containment measures then included travel restrictions, temperature screenings, as well as quarantine for certain groups of people. Unfortunately, the number of COVID-19 positive cases rose alarmingly, leading to the then implementation of the circuit breaker measures by the Singapore government to last for 2 months from April to June 2020. This actually meant the closure of all schools, institutes of higher learning, and non-essential services. Home-based learning and working from home became the new default. Everyone was required to remain at home except when attending to essential needs, and masks were to be worn all the time when going out, and also safe distancing of at least 1 meter was required. The aim then, as what we call it, was to flatten the curve and reduce community spread. So these restrictions also applied to hospitals in order to limit contact between healthcare staff from different institutions, staff from different disciplines, as well as interaction with patients. We also need to channel our resources to address COVID-related issues, and that required the reduction of non-essential patient activities. Of course, that will include non-critical outpatient appointments as well as surgeries. Changi General Hospital, or in short CGH, is one of the 13 public hospitals in Singapore that manages COVID-suspected and positive patients. Management of breast cancer patients requires a delicate balance between achieving the best oncological outcomes while not increasing the risk of severe acute respiratory syndrome or SARS-CoV in this vulnerable group. There was a previous study in China where a nationwide analysis of cancer patients was conducted, and this study concluded that patients with cancer might have a higher risk of COVID-19 and poorer outcomes as well. So breast cancer, in fact, I think is the most common cancer not only amongst women in Singapore, but worldwide. The Division of Breast Surgery in CGH is a full-fledged tertiary referral center that delivers one-stop comprehensive care to residents living mainly in the east of Singapore. We have 4 full-time specialist breast surgeons and 2 full-time non-specialist doctors. In addition, we also have 6 external doctors from different institutions around the country who come to the center on a regular basis to provide outpatient consultations and be part of our multidisciplinary meetings. Our division is also an accredited assessment center for Breast Screen Singapore, and Breast Screen Singapore is a nationwide breast cancer screening program managed by the Health Promotion Board in Singapore. Furthermore, our doctors are also teaching faculty for 3 medical schools in Singapore, and we are also part of our surgical residency training program. Just to give a little bit of background on our workload, from the year 2015 to 2019, our total outpatient clinic visits number at approximately 30,000, and we have a relatively high operating volume of about 2,500 breast surgeries, including oncoplastic as well as reconstructive surgeries. So because of all this and because of COVID, we have to adapt. And what do we do to adapt in our clinical practice? First, I would like to discuss with all of you about our outpatient clinic visits adaptation. So as I've mentioned earlier, at the start of COVID in February 2020, Ministry of Health declared DOS gone orange, and essentially it meant a certain degree of lockdown of healthcare staff to their own institutions. Cross-institutional activities were actually not allowed. As a result, as I mentioned earlier, we have 6 external doctors. They could not come to our hospital to provide outpatient consults. Our in-house doctors then had to take over the care of their patients, which led to a sudden increase in outpatient load for us. To cope with this surge, we reviewed the clinical records of these patients to determine their need for their clinic review. Those who are coming for routine follow-ups for benign conditions, their appointments will be postponed to a later date. Patients with abnormal investigation results or when otherwise on follow-up for breast cancer continued to be seen. Any such patients who did not attend their scheduled appointments will be contacted by our nurses and their appointments rescheduled. Should they then decline to come due to the fear of contracting COVID-19, their particulars will be recorded in a secure database in order for us to contact them once the situation improves. The nurses would also check if they had adequate medication. In order to cope with this sudden influx of patients who were not previously under our care, we actually reviewed their patients' records in our electronic health record system prior to their appointments to summarize all their issues. And this definitely helps to facilitate the simplest transfer of care from the external doctors to us. In addition, we're just worried should any of our doctors were to become unfit to work either due to quarantine or due to exposure to COVID-19, another colleague can then fill in the gap with little compromise to patient care. In addition, our clinic resources of both our external doctors and ours were suspended to cope with the increasing load. This meant that existing appointments were actually maintained, but we don't add any additional appointment slots to that. However, as we are a tertiary referral center, appointment slots for urgent new referrals were not suspended. And these include cases of breast abscess, suspicious mammogram or ultrasound findings of BI-RADS 4 or 5 categories, which means that potentially they can be suspicious, and any patients with suspicious signs or symptoms of breast cancer or newly diagnosed breast cancer will continue to be seen. The adjustment of our clinic resources were initially implemented from February to May 2020. Hence, all non-critical patients' appointments were postponed until June. However, when COVID-19 was declared as a pandemic and the situation worsened in Singapore, these clinic suspensions were then extended to December last year. This allowed us to cope with the postponed cases and also to prepare for the possibility of deployment of our staff to COVID-19 areas. So then that was from February to March. In April 2020, as the situation worsened, the Ministry of Health of Singapore announced the circuit breaker measures. And the circuit breaker measures essentially meant a certain degree of lockdown. And it included a set of essential face-to-face medical services that require certain changes. And these include cancer services, which when delayed will increase, of course, the chances of relapse or deterioration. Our outpatient load actually consists of patients with both cancer and non-cancer conditions. And the non-cancer patients that we kept are mainly those with high-risk lesions, strong family history, or breast imaging abnormalities. With the commencement of the circuit breaker measures, the Ministry of Health mandated that all non-essential patient visits to the hospitals to be postponed. To do this, we collated a list of all the patients coming in for consultations from April to June 2020. These patients' records and any recent investigation results were reviewed. So the following are the list of patients whose outpatient appointments were not to be postponed. Firstly, of course, patients with newly diagnosed breast cancer patients, or patients who are on routine follow-up within the first 2 years of their treatment, as the risk of recurrence within the first 2 years of treatment is higher. We will also continue seeing non-cancer patients, but with recent investigations results revealing abnormalities, and these abnormalities could be malignant. And of course, any patients with recent new onset of symptoms, we would not delay their diagnosis and treatment, hence we will continue seeing them. Our nurses would then contact patients again, and this is where I think a multidisciplinary team approach is very important, because we have a very good support system from our breast care nurses who would actually contact the patients to tell them that their appointments can be safely postponed and to make sure that they are not symptomatic and they have sufficient medication for those patients who are on endocrine therapy, for example. Any patient who was symptomatic during our nurses' contact would be advised to come for their original appointment. So within 3 days of looking through all the records, we actually looked through about 450 records and reduced the number of outpatient consultations to 24% of the original numbers. And this was subsequently done for the month of May and June as well. So this is a very simple table to summarize our principle for outpatient visits management. We try to minimize outpatient visits as much as possible, to replace it with telemedicine or teleconsult if appropriate, and priority are given to conditions that, when delayed, would increase the chances of relapse or deterioration. I would like to show and share some pictures of what we do in our outpatient clinic after
COVID-19. So you can see here at our registration counter where my patient service associate or nurses register the patients and process their payments. We have this barrier here to actually protect them, and of course we make it as spacious as possible. We space out wherever we can. And this is our patient waiting area. As we can see here, so, the safe distancing. Basically, we space out the areas on the seats available, and of course, set constant reminder for our visitors or patients.
So during these few crucial months where COVID-19 cases were on the rise, screening was deemed a non-essential medical services and was thus suspended when the circuit breaker was implemented. However, women who were recalled for abnormalities detected on their screening mammogram that was already performed continued to be reviewed by our breast radiologists, because we felt that evaluation of these ladies should not be delayed, as they do have a higher risk of malignancy in view of the abnormalities. So the attendance rate at our screening clinic were well maintained, with only about 10% of ladies calling in to postpone their appointments. And this were quickly filled by others who requested for earlier appointments. We feel that the ability to maintain healthy attendance rates amidst our limited resources again required great team multidisciplinary effort, in this case between the radiologists and surgeons. And this is to summarize our approach to screening and imaging. Try to minimize hospital visits as much as possible. We defer all screening imaging for at least 6 to 12 months, and we give priority to conditions that when delayed would again increase the chances of relapse or deterioration. So next, what about surgery cases? Our division of breast surgery is part of the Department of Surgery, and we do have other subspecialties in the department, such as upper gastrointestinal surgery, colorectal surgery, head and neck surgery, hepatobiliary surgery, vascular surgery, as well as plastic and reconstructive surgery. While vascular and plastic team have their own operating theatre list, the rest of the department share 3 operating theatre lists on a daily basis during the period of time. Before COVID-19, our division was allocated 2 operating theatre lists a week. And most of our surgeries are performed on a day surgery or 23-hour ward, that means a one overnight stay basis. And this applied to therapeutic breast cancer surgeries, including higher level surgeries such as oncoplastic and reconstructive surgeries. Patients who require longer stay, for example, are those patients who underwent a free flap or autologous flap reconstruction, such as TRAM or DIAP flap. And our day surgery and 23-hour wards are both located in a separate facility from our inpatient wards. We think that this is definitely good in the context of COVID-19 because this practice actually limits the exposure of our patients and clinicians to the general hospital cohort. So when DORSCON Orange was announced in February 2020, of course, that led to a reduction of resources, and that included staff, especially nursing staff and anesthetists running the operating theatres because they are deployed to COVID-19 areas. So this is when the hospital implemented a cohort-based OT booking system for elective surgeries. That means the whole Department of Surgery will share 1 operating theatre on 3 days and 2 operating theatres on 2 days per week. This actually resulted in the reduction of OT allocations for the division of breast surgery to just 1 full operating theatre list per week. So then we decided that all benign, non-urgent diagnostic breast surgeries were postponed indefinitely, but patient details were recorded in a secure database so that we can contact them to reschedule their operation when the situation permits. The priority during this period of time was thus given to oncological cases or cases that were deemed indeterminate and required diagnostic surgery. We still offered immediate reconstruction options such as autologous or implants and oncoplastic surgery where the operating theatre list is available and where we think that the time taken for the operation is still within acceptable period. So unfortunately, by March 2020, our wait time for breast cancer surgery was beyond 6 weeks. And this was unacceptable to us, so we appealed for more operating theatre lists and that was successful, leading to an increase in theatre lists to 2 per week for the division of breast surgery. With that, we were able to reduce the wait time to about 3 weeks. So then again, come April, as the situation worsens, there are more deployment of staff to COVID-related areas, and this led to further reduction in our operating theatre list. But the good thing and the blessing in disguise is that because of COVID as well, there's a reduction in the number of clinic attendance and outpatient clinic visits. We have a concurrent reduction in newly diagnosed breast cancer case. Hence, the operative wait time for cancer patients was not any longer than before. So on top of that, with regards to surgery, we actually had team segregation. So in our division, we segregated our staff into 2 surgical teams, and each team consisted of 3 doctors, a senior specialist surgeon, a junior specialist surgeon, and a non-specialist doctors. And we confined ourselves strictly to our teams when performing surgery, and this was because during the surgery, it is impossible to maintain a safe distancing of 1 meter between the staff and patient. In addition, because studies have shown that aerosolization of the SARS-CoV-2 virus has been reported when energy devices such as diatomy pens are used. Hence, we're worried should the patient subsequently be diagnosed with COVID-19, only the surgical team who were involved in the same operation needs to be quarantined. The rest of the team or the other team will still be able to run the service and will not compromise on patients' care. Likewise, we conduct our inpatient ward rounds and outpatient clinics in a similar manner. So we also reviewed the nature of operations that we conducted. Therapeutic surgery for breast cancer and diagnostic surgery for suspicious lesions continued, but they're all performed by the most experienced breast surgeon in each team. Newly diagnosed breast cancer patients who then opted for immediate breast reconstruction post-mastectomy with the TREM or DIEP flap were advised to have expander implant inserted instead, with subsequent definitive reconstruction. This was done to shorten the operative time, the length of inpatient stay, and of course to reduce complication risk. So as per hospital guidelines, surgery for suspected or confirmed COVID-19 cases are performed under full personal protective equipment and powered air purifying respirator respectively. This is a summary of our approach for surgery during this period. We only perform surgery for urgent or life-threatening conditions. Oncologic resection achieved with the shortest anesthesia, the least mobility, the shortest hospital stay, and fastest recovery will be chosen. And of course, in certain cases, we consider alternatives to surgery. This is a simple sharing from myself. This is the number of oncological resections that I've performed over the past 1.5 years. You can see that this has not differed a lot from the pre-COVID times for myself, and it is because of all this arrangement and a multidisciplinary team effort from everyone from my team they were able to achieve good oncological care for our patients with breast cancer. Next, we'll move on to systemic treatment and radiation. So breast cancer patients, some of them will require systemic therapy or radiation after their surgery, and these recommendations were made at our multidisciplinary meeting. These meetings continued during this period because we do not want to compromise patient care, but we make sure only essential staff needed to make crucial management decisions are present. And when the circuit breaker measures were implemented, we switched all our meetings to virtual via teleconferencing. And these measures were all taken as part of a multidisciplinary effort in order to ensure timely delivery of care for our breast cancer patients while we keep to our safe distancing safety measures. So for patients who require systemic or radiation therapy, we were mindful to ensure safe distancing, we minimize immunosuppression, and reduce unnecessary visits. So we have to suspend all other non-clinical activities during this period. For example, education, whether it's continued medical education for our staff, undergraduate students, or postgraduate students. So all non-essential academic meetings were cancelled to minimize contact between staff. And our journal ratings, our journal club were conducted online with sharing of interesting journal articles. During this period of time, formal lectures and bedside tutorials were suspended as well. And for students, all elective attachments were cancelled. All our medical and nursing schools affiliated to our institution suspended their clinical attachment during this period of time and replaced with home-based online learning. All this for the same reason, to minimize exposure to potential COVID-19 patients. Clinical research for this period of time were also suspended. And for breast cancer, we used to hold support group events for our survivors and volunteer training programs, but they were all put on hold during this crucial period of time. Patients continued to have standard counseling by our doctors and breast care nurses on a one-to-one basis as well. So we believe that during this period of time, despite our best efforts, there will be certain impact on patients. The magnitude of the long-term implications due to the reduction in clinical activities is currently still unknown. But we have noticed that patients who have either deferred or failed to attend their hospital appointments have increased during this period of time and actually ever since then. And this is due to the fear of contracting, getting COVID-19 in a hospital. However, we believe that there is a chance that all these postponements may lead to a delay in diagnosis and treatment. So for undetected malignancy, this delay in diagnosis and treatment might inevitably lead to unfavorable long-term outcomes. So as the number of COVID-19 cases increases, we believe that more resources will be channeled towards the areas in need. And we're very lucky that despite all this, we're able to keep our wait time to therapeutic cancer surgery to about 4 weeks. However, patients opted for longer surgery, such as a free autologous flap reconstruction, will have to undergo stage surgery with all our recommendations. And this will of course incur higher total treatment costs, as well as having to undergo another general anesthesia, along with its inherent risk. And of course, the cosmetic outcomes also may not be as ideal as immediate reconstruction. When we suspend patient support activities, there may be a certain degree of psychological impact on their patients and families that may not be immediately apparent. And without these services and activities, patients as well as their families lose an avenue to share their concerns and worries. They may also feel alone in their cancer treatment journey and may be deprived of coping techniques to deal with the stress. And similarly, the caregivers can also develop caregiver stress that is not addressed, may lead to adverse psychological outcomes. So we feel that COVID-19 has taught us a lot of things, and while managing our breast cancer patients, while making sure that their care is not compromised, we do learn. So most importantly, we learned that multidisciplinary efforts from important stakeholders in breast cancer care is very important, and I cannot emphasize more on this. And this includes, but not limited to, surgeons like myself, our radiologist colleague, medical oncologists, radiation oncologists, pathologists, and our breast care nurses. And I really believe and feel that it requires a concerted effort from all of us to ensure timely delivery of standard of care in this new normal. So I would like to share the other paper that my team and myself have published last year as well. And this is what we call as a prioritization aid to help others who may be in the same situation as us in order to maximize and optimize patients' care. So we prioritize for outpatient visits scenarios that we advise not to be postponed, or conditions that we feel can be postponed. So I wouldn't go into the details of it, as I believe that all of you can read up on this article during your free time. But essentially, we keep anything that is urgent, patients that are symptomatic, on our list, while the rest are postponed. We also prioritize the management of breast cancer, and this we stratified it according to the DORSCON level as well as resource availability. Essentially, the principles are similar to what I've explained earlier. However, in terms of resources, if it is limited, we actually stratify the patients further according to their priority, whether they're high, medium, or low, and we make our recommendations to either keep or postpone the appointments. So for surgery, as I mentioned earlier, we do not exclude all reconstructive surgeries as long as the surgeries can be done in a timely manner within an acceptable time frame. We still allow the reconstruction to take place. And for systemic treatment and radiation therapy, if patients need it, they will still go for it, but we try to minimize drugs or chemo drugs that are extremely immunosuppressive in order to manage patients better during this period. And so, what are our updates since last year? As I put it here, I think virtual is the keyword. Virtual is the future now. Why I say so is because everything can be done virtually online now, and I feel that that is what COVID-19 has taught us. Everything from our multidisciplinary team meeting to our education, whether it's for doctors, trainees, or nurses, even our breast cancer patient support group are done virtually and online now. And we have since started telemedicine in the form of phone consultation as well as video consultation for some of our follow-up patients. In clinical practice, we have tried a lot of new technology and equipments to actually reduce operating theatre time or to decouple the surgery and radiology schedule. And I think all this can't be done without a concerted multidisciplinary team effort. So for this, I'm very thankful to everybody in my division and all the specialists and the support staff that have worked together with us to provide optimal and timely care for our breast cancer patients. And with that, thank all of you for listening in to me today. And meanwhile, I hope everyone will stay safe and healthy. Last but not the least, hopefully when the borders are open, I hope to see you guys in Singapore. Thank you very much.